attention to the management or the treatment of multiple system atrophy. We can move to the next slide. And here I've just listed what I think are some general principles of treatment, really based on my personal experience for the most part. I think it's best for most patients to have the diagnosis confirmed by a movement disorders neurologist. I'm a little biased, but in most experiences, in most times, I think you need to have a specialist to be able to put all the information together and confirm that MSA is indeed the most likely diagnosis. I think one area that still is very hard in terms of diagnosis is separating multiple system atrophy from Parkinson's disease with autonomic dysfunction. And people with Parkinson's disease often have the same things that Dr. Coulter listed for autonomic dysfunction: gastrointestinal problems, orthostatic hypotension, urinary problems, erectile dysfunction. And many times it's just very hard to draw the line and say, well, you have too much autonomic dysfunction to call you Parkinson's disease. And a lot of times it's really based on the experience of the physician, as Dr. Coulter said. Sometimes you just need time. Time kind of sorts it out. People with multiple system atrophy do tend to progress at a faster rate. They tend to have more of a worsening of the autonomic problems over time. And sometimes we can say at the beginning, you have Parkinsonism, you have autonomic dysfunction. We're dealing with either Parkinson's disease with autonomic dysfunction or MSA, and we'll follow it along and see how things go. And that's a lot of times the best we can do, particularly since we don't have reliable biomarkers, what Dr. Coulter was talking about. We don't have a test, we don't have a blood test, we don't have an MRI or a PET that can distinguish between MSA and Parkinson's disease with autonomic dysfunction, for example. We can sometimes see in MSA some changes on MRI that might distinguish them. In MSA, many times there is more atrophy or loss of brain substance in a part of the brain called the midbrain. Also with the MSA-C, the cerebellar type, we do see atrophy of that part of the brain called the cerebellum. So sometimes there are tests that can help us really get closer to knowing whether it is indeed MSA or particularly one of the other Parkinsonian conditions. I think generally it's also best to have your overall treatment and management headed up by a movement disorders neurologist. This is the specialty that generally takes care of people with MSA. I think in most situations, general neurologists are just not equipped to do it. MSA is a fairly complicated condition to treat. And I think you're in best hands when you see a movement disorders neurologist. Because it's complicated, I think many times patients do best when they have a multidisciplinary team of physicians. In particular, many people with MSA do best when they have not only their neurologist, but they have a gastroenterologist and also a urologist. And for most of my patients, I have them see myself and on a regular basis a gastroenterologist and a urologist throughout the course of their illness. Again, these specialists are most up to date on what the latest treatments are. They have most experience in knowing about combinations of treatments. And I think you're best off, again, getting specialist help for your special problems. One thing that I've experienced over and over again in trying to treat orthostatic hypotension in patients with MSA is I give medications to raise the blood pressure, especially the lying or supine blood pressure, and then the patient goes to their internist or cardiologist, and they back off the treatment that I just gave. And it's to the detriment of the patient. Many times you do have to have a fairly high lying blood pressure in order to not have too low of a blood pressure. when you stand up. And sometimes that line blood pressure has to be pretty high, in the 190s, 200s. And internists and cardiologists get scared because they're thinking about heart attacks. But neurologists understand that it's important to maintain good blood flow to the brain. And as a neurologist, we know that the brain is the most important organ in the body, and the whole body was created just to keep your brain healthy, right? So next slide. Let's talk about each aspect of MSA. So we'll start with Parkinsonism. So Parkinsonism, that term means you have features that resemble Parkinson's disease. But the implication is it's not Parkinson's disease, it's another condition like MSA that can have very similar symptoms. So Parkinsonism implies slowness, like bradykinesia, stiffness, or what's called rigidity. There may or may not be tremor. Usually there's problems with posture, gait, and balance. And that kind of combination of problems we call Parkinsonism. And generally we treat the Parkinsonism pretty similar to how we treat Parkinsonism in Parkinson's disease. But I think there are a few exceptions generally, again, based on mostly my experience. I find that people with MSA seem to do the best on only one Parkinsonian, anti-Parkinsonian drug, and that's levodopa carbidopa, or what you might know as Sinemet. There are a whole variety of different medicines that one can use to treat Parkinsonism. There's amantadine, there's anticholinergic drugs, there's dopamine agonists, there's MAO-B inhibitors, there's COMT inhibitors. But in my experience, the most benign and well-tolerated drug for Parkinsonism in people with MSA is just levodopa. And I tend to manage patients just with levodopa throughout the majority of their course. Occasionally, this isn't a hard and fast rule, and occasionally I will throw in one of those other drugs. For example, the drug amantadine I find is often helpful in people who have particular balance problems. They tend to fall backwards and what's called retropulsion. And if that's a major problem for the patient, sometimes I'll add some amantadine. The biggest problem with those other medications is that they tend to drop the blood pressure. So they tend to be more potent in dropping the blood pressure than levodopa. But levodopa itself can also worsen the low blood pressure, and it's always the balance between control of the Parkinsonism and control of the blood pressure. So you always want to use the lowest dose that allows satisfactory motor function, satisfactory control of the Parkinsonism. Okay, next. Now another very common, maybe one of the most common features of MSA is the constipation. And for many patients, this is their main complaint. They're very focused on their bowels. When they're constipated, they're very uncomfortable. But there are a lot of things that we know of that can be quite helpful for constipation. So diet is important. You especially want to have high fiber in your diet. Very critical is fluid intake. And I think that the two things that I find that patients fail to do in terms of treating their constipation is, number one, is that they don't have an adequate fluid intake. And number two, which is the next thing, they don't exercise. You have to take in quite a bit of fluid, actually. So I recommend about 2 quarts of fluid every day. I tell patients to take a 2-quart container, fill it up with something they want to drink that day, put it in the refrigerator, and try by the end of the day to make sure that 2-quart container is gone. Now, one of the big problems with MSA is that most people have to pee all the time, and they have to do it urgently. So there's an automatic cutting back on fluid. And so because of one problem, you create another problem. And so my general advice is, well, when you're home close to your bathroom, do the drinking. When you go out, don't do so much drinking. But you've got to get that fluid in one way or another. But it's a big problem, again, mainly I think because the urinary problems, people stay away from fluid. Another thing is, as people age, they tend to lose their sense of thirst. So someone may become quite dehydrated and not feel thirsty. So you can't just drink when you're thirsty. You have to actually fill that 2-quart container in the morning and finish it by the end of the day. Exercise, we think, is very important for moving the bowels. When you move, the bowels move, and exercise is a critical part of controlling constipation. If you are immobile, you're not up and around, you're going to be constipated. It's just what the physiology is. So exercise is a very important part of controlling constipation. You kind of need a little bit of each form of treatment for constipation. So one is a stool softener, and the most common one is one called Colace. Many people take it once a day, but you really should take it twice a day. Seems to work the best. The second aspect of treating constipation is a bulk agent, and a good one and a very commonly used one is Metamucil. Metamucil comes as a powder, it comes down in capsules, there's different ways of taking it. You want a stool softener, a bulk agent, and then you want something that helps motility. And Miralax is a relatively new medication. It basically is a glucose formula, and when you take Miralax, it's in your gut, it's in your bowels, and it absorbs fluid in. Remember, Dr. Coulter told you how with MSA, because of slow motility, the intestinals are constantly removing fluid as the stool gets harder and harder. The Miralax kind of reverses that, draws fluid into the bowels and helps the bowels move. There is a medication we use every once in a while. It's mostly used for irritable bowel syndrome, but it seems to help many times with people with MSA and constipation. Is a medicine called Amitiza. And my general approach is I'll try all of those things, and then if we're not successful, then it's time to go see a gastroenterologist, see a specialist. Let's go to the next. Orthostatic hypotension is probably the second most disabling aspect of MSA for most patients. And it's a pretty complicated area in terms of how to treat it. It's often very difficult to treat. But there are a series of interventions that can be extremely helpful. Most important, for starters, is the same thing I talked about for constipation. You just can't let yourself get dehydrated. So dehydration is a major contributor to the drop of blood pressure when somebody stands. So that 2-quart container for constipation also holds for blood pressure, orthostatic hypotension. And then you want to have extra salt in your diet. You've always heard about how you're supposed to avoid salt. Well, that's for high blood pressure. And here we're in the opposite situation. We're dealing with low blood pressure. So you want to salt your foods, or you want to have salt tablets. You can buy salt tablets, either 500 milligram or 1 gram tablets, and most people should have a gram or 2 of salt extra every day. There's often a problem that the person who has MSA needs more salt, and the spouse has high blood pressure, needs less salt, and so you battle it out. There's no easy answer for it. You usually kind of stuck making the food low salt for the spouse who needs low salt, and then the person with MSA just pours the salt on that, or takes their salt tablets. But salt is important. It's very useful to put the head of your bed on blocks, and so you generally want to get something like a concrete block that's used in construction of houses. that gives you about the right angle. You want the head of the bed elevated enough so that the bed is about 30-degree angle. So the head is elevated, the feet are lower. It does not help if you just elevate your head on a bunch of pillows. You have to have the entire bed at a 30-degree angle. And what that does is it activates your body's hormone system, aldosterone and other hormones that prevent low blood pressure. And so you want to be doing that constantly by sleeping in a bed that's in this 30-degree angle. Elastic stockings is another very good tool. Generally, we start with the knee-high elastic stockings. They're called tent hose. They're the ugly white stockings that you always wear if you're admitted to a hospital that are designed to prevent blood clots forming in the legs. But the elastic stockings can also help blood from pooling in the legs when somebody stands up. If the tent hose are not satisfactory, then we can go to what are called Job's stocking, J-O-B-S-T. They come up to the hips generally, and usually they're made on an individualized basis. The store will measure the size of the legs and order proper size Job's stockings. The stockings are generally worn from the time you wake up in the morning to the time you go to bed at night. You don't sleep in them, but you don't take them off during the day. The first medication we typically start with is something called fludrocortisone or Florinef. This is similar to our own hormones that exist, but it kind of forces the body to keep more salt, to reduce the excretion of salt in the urine. And so it's very much like giving salt substitutes. There's another medication that we frequently use called midodrine. This medicine causes the blood vessels in the legs to contract. When they contract, the blood doesn't pool in the legs quite as much. So those two in combination, they each work by different mechanisms, but they work synergistically together. One of the newest medications that's now out now is called droxidopa. Northera is the brand name. And this is a medication that we often try, especially if the fludrocortisone and midodrine by themselves are not satisfactory. I think there's a table out front talking about Northera and midodrine, droxidopa. And then sometimes we have to do crazy things. Some people just pass out every time they sit up or they stand up, and that's no life. So there's some things that we get aggressive about and try to maintain the blood pressure. Occasionally, I've used what's called a high-pressure bodysuit. These are things that are used in diving or aeronautics. And basically, it's a whole body suit that you pump it up with air, and it pressurizes the whole body, and it can help orthostatic hypotension. And usually, the last resort is what's called rapid cardiac pacing. Is the patient is sent to a cardiologist, a heart pacemaker is placed, and the rate is set at a high level, and that rapid pacing will also often compensate, well, sometimes compensate for the drop in the blood pressure when someone stands up. So there's a lot of options for treating it, and usually we can get fairly good control of the orthostatic hypotension. Next. The urinary symptoms, I generally do recommend working with a urologist. I think that's the best option. The available treatments for the urinary problems change a lot. New medicines come on the market fairly quickly. The best way to treat the urinary problems is to know what the urinary problems actually are. And for the most part, that requires a urologist to do some testing of bladder function, typically called urodynamics. It's not something that a neurologist would do. But they would put a catheter into the bladder and measure different pressures and a variety of different other measurements and see exactly what the problem is. Why do you have urinary urgency? Why do you have urinary incontinence? And then the treatments can be directed better once you know exactly what you're dealing with. There are a whole variety of medications on the market now to treat urinary problems. You've heard of all of them: Flomax, Detrol, Dipropan. It's hard to watch TV for longer than 10 minutes without seeing an ad for overactive bladder. They even have little bladders leading people around. It's a little much, but it is a field that does change very rapidly. So I think you're best off not just blindly using medications to treat urinary symptoms, but seeing a urologist, get a good urological evaluation, and figuring out what the best treatment is. One of the newest treatments really has become quite effective, and this is something urologists do as well, which is to inject something called Botox into the bladder muscles, and that can decrease the spasticity of the bladder, the spasms of the bladder, and can be dramatically helpful for people with overactive bladder. You've probably heard of Botox. It's all the Hollywood stars get it before every night into their eyelids. But it's used in movement disorders for a lot of abnormal movement disorders, but it can be extremely helpful when it's injected into the bladder. And then if none of these treatments are adequate, the last step generally involves some sort of catheterization. So these are either self-catheterizations or some kind of indwelling catheter, either something called a Foley catheter or one that's inserted in what's called the suprapubic catheter that's permanently placed. And so, as I said, for the other things, there are a number of treatments available for the main features of MSAs. It's really trying to individualize them, but there are pretty good options for most people. Next. Erectile dysfunction, I think also it's best to work with a urologist. One of the things I've found that's sometimes missed in people is that, especially males, is that there is a low testosterone level, and a decrease in testosterone seems to occur in many men just as part of aging. And sometimes just replacing the testosterone can improve the erectile dysfunction. So people shouldn't forget to make sure that their testosterone level is checked. There, of course, are a variety of medications. Ads for these occur even more often than the bladder, especially during high testosterone male things like Super Bowl, NCAA basketball tournament. And then the urologists have a number of devices that are available if medication treatment fails. And then I wanted to just conclude the discussion of management by saying that it is important to focus and not forget other health issues. The MSA is going to be worse if you're suffering from other uncontrolled medical problems. So you want to make sure that the rest of you is as healthy as possible. So you want to optimally control heart problems, blood pressure problems, diabetes, et cetera, et cetera. I have on here exercise, exercise, exercise. If there's one kind of key advance in treating Parkinson's disease and Parkinsonian disorders that's really made a difference in people's lives in the last couple of years, I think it's the recognition that vigorous aerobic exercise really changes the progression of Parkinsonian disorders. So aerobic exercise does a number of good things in the brain. It increases blood flow to the brain. It decreases inflammation. There's some evidence that inflammation contributes to the loss of brain cells in MSA and Parkinson's disease. It stimulates the release of chemicals called trophic factors. These are chemicals that help strengthen the brain cells that are degenerating. It also inhibits something called programmed cell death or apoptosis, and that's something that kicks in whenever there's an injured nerve cell. The body has natural reactions to try to rid itself of that injured nerve cell, but we really don't want that to happen in a degenerative disease. We want even injured nerve cells to survive as long as possible. So exercise just seems to be a very powerful, potent treatment for all Parkinsonian disorders. So it's generally recommended that if you can, people do at least 30 minutes of aerobic exercise 3 times a week. So that's kind of a minimum. Aerobic exercise is exercise that increases your pulse rate, your breathing rate, and you generally want to build up a sweat. And it's pretty clear that people who do vigorous exercise from the start of their diagnosis just seem to have a much better course over time. And I think this holds for Parkinson's disease and also MSA. So you want to do everything you can to try to exercise as best as possible. I think some other things, mindfulness activities like meditation, yoga, Tai Chi, may have some benefit in terms of helping with body movement, helping with coping skills. Tai Chi is said to be particularly helpful for balance difficulties. And these are things a lot of people enjoy. They enjoy doing it with a group, and they're useful things. Depression and anxiety are both common features of all the alpha-synuclein disorders, and they may be major contributors to someone's difficulty with daily functioning. So it's important to recognize depression and anxiety and treat them appropriately. I put up your vegan diet with a question mark. Anecdotally, I've actually seen a couple of patients recently who have, with MSA, both of MSA, who switched to a vegan diet. Both of them have had the illness for at least 5 years. And after they switched to a vegan diet is all plant-based food. There's no eggs, there's no cheese because it comes from milk products which come from an animal. Vegan diet is purely vegetable-based. But both of these patients have had a very dramatic improvement in their symptoms. And I don't know exactly what to make of it. We're going to start a research study to try to look at it in more detail. But in my experience, it just seemed more than one would expect with this sort of change. We do know that the medications for the Parkinsonism, like levodopa, compete with amino acids that come from food in the diet, especially meat products. So it's possible that a vegan diet may allow their Parkinsonian medications to work better. But the change in at least 2 people were so dramatic, I'm kind of thinking there's more to it. But I can't really recommend it because it's so anecdotal, but it's something that we're going to look at in a more formal sense. It's important to think about strengthening your coping skills, and this can come from support groups like the MSA group that meets at Overlook. Individual counseling may be needed, family counseling. These are things that people really aren't put together a lot of times to cope with some very difficult, progressive, degenerative illnesses. And there's nothing wrong with getting help from a professional who really can help people and families come up with positive coping skills. And it's important to think about that. And just at the end, I mentioned, don't forget the care partner. All the focus usually is on the patient with MSA, but it's devastating for the care partner in many ways, with the physical burdens, the emotional burdens, often financial burdens, et cetera, et cetera, et cetera. And so we can't really forget the care partner. And the care partner may need help in terms of their coping skills, whether it's having some free time to relax on their own or exercise, or getting involved in counseling themselves. So that's an important part of treating MSA, is to think of the family and the spouse. So this is what I have on treatment. I was asked to say a few words about research for MSA. Say in one big summary, the research for MSA is very disappointing. There's very little research that's directed at MSA itself. MSA really gets its research from its rich cousin, Parkinson's disease. So there's so many things that are similar between Parkinson's disease and MSA that people hope and think that research in Parkinson's disease, if it's successful, is going to spill over and help people with MSA and the other synucleinopathies. Also, there's more focus on Parkinson's disease. There's more money put toward Parkinson's disease research. And Parkinson's disease research really guides research that's relevant to MSA. So everything that you might have heard about of research directions in Parkinson's disease that is looking at oxidative stress is a major area, looking at medications that reduce oxidative stress, mitochondrial function, those energy-producing components of brain cells. Those are areas of major focus in Parkinson's disease, and they're being tested in MSA to some extent as well. Stem cell research is being looked at in Parkinson's disease. And again, the hope is if it's helpful there, it's going to spill over into MSA. Probably the one exception for specific MSA-related research is research looking at orthostatic hypotension. There are a number of studies going on to look at newer medications to treat orthostatic hypotension. That's more of an issue for MSA usually than Parkinson's disease, but there isn't a lot of research directed specifically for MSA. Probably the main focus of research comes again from Parkinson's disease, and that is the new recognition that this protein, alpha-synuclein, builds up, aggregates in the brain cells, and likely in some way contributes to the death of those nerve cells. So the buildup of the protein interferes with the normal transport of materials within the nerve cell. It seems to interfere with the mitochondria, the energy source. It interferes with the riddance of the cells of various toxins. It's a bad actor. Nobody knows exactly why it causes cells to die, but it seems to be an important factor. So the biggest area of research recently in Parkinson's disease, which will translate to MSA, are looking at treatments that either prevent the aggregation and accumulation of the alpha-synuclein in the brain cells, help degrade the aggregated alpha-synuclein, or somehow go in and disrupt and break up the alpha-synuclein aggregates. So there's all sorts of medications, antibodies, other approaches that are being looked at, gene therapies that are being looked at to try to interfere with this whole pathologic alpha-synuclein process. And this is probably where the focus of research is going to be for the next several years, until it's either successful or we realize that it doesn't work. The same focus is going on for essentially all neurodegenerative diseases now, but they're different proteins. So in Alzheimer's disease, everyone is looking at medications to prevent the aggregation of a protein called amyloid. In other illnesses, frontotemporal dementia, for example, we're looking at medications and treatments to prevent the aggregation of a protein called tau. And it just goes on and on and on. This seems to be a universal process in neurodegenerative diseases. It's just the illnesses, each illness has a different protein. The protein aggregates in a different set of nerve cells. Whatever nerve cells are affected dictate what the actual symptoms are of the illness. And the general strategy for all neurodegenerative diseases is now focused on trying to break up those aggregates or prevent them from aggregating at the beginning. And this is, I think, what the future of MSA research is going to hold for a while. There have not been any breakthroughs yet in humans. There are a number of interventions that have looked very successful in the laboratory with either in cultures or with animals, but there has not yet been any real breakthrough with human neurodegenerative diseases, but everyone's hopeful that this is a strategy that will pay off. So I'll stop there, and I think maybe Amy and I can both take questions.
Okay.